Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Early stage breast cancer patients now have an expedited, a much faster treatment option at the Mayo Clinic. Certain low-risk patients can have their surgery and their radiation in less than 10 days, believe it or not.
The Expedited treatment program combines lumpectomy surgery with a type of internal partial breast radiation called brachytherapy. Here to discuss...
Well, you said it exactly right. Achy brachytherapy. Yep.
Here to discuss the Expedited breast cancer treatment is the Mayo Clinic breast surgeon who helped design the program, Dr. Tina Hieken. Welcome to the program, Dr. Hieken. It's great to have you here.
Thank you.
Dr. Hieken, nice to meet you. Nice to have you on the program, and especially to talk about this, the 10-day breast cancer treatment regimen. And tell us about it.
So for selected women, those with early stage breast cancer, small tumors that measure less than about an inch in size, and that have the characteristics of most breast cancers, that is that they're estrogen receptor positive, who also have no evidence of any clinical lymph node involvement, may be eligible for this approach.
So localized to the breast. Sorry, go ahead.
Well,
and then I want to ask you, estrogen positive? And
Yeah, so that's what I was going to say. Who are these specific women? You said for certain women, so what makes them eligible for this?
So for now, we're limiting this mostly to women who are postmenopausal, those who are at about 50 years of age and older, and women who have these characteristics of a tumor where it's estrogen receptor positive.
And what does that mean? And why these women?
So these are generally women who have a lower risk of having the breast cancer come back, either locally in the breast, in the regional lymph nodes, or elsewhere in the body. And a lot of evidence over many years has shown that the place where they're at the greatest risk of having cancer come back, if it comes back at all, is right there in that same part of the breast that the tumor was removed from.
So women with estrogen-positive breast cancer in general have a good prognosis if you cure the local disease.
Correct.
So tell us how you do this exactly. I mean, how do you, you mentioned the criteria. Once you have a woman like this, estrogen positive, localized to the breast, what happens next?
So for women who are interested in this approach, we discuss with them what this involves. So you have behind you the little illustration showing our catheter. So at the time that we take them to the operating room, we remove the tumor. Our frozen section pathology group checks to make sure that we've completely removed the tumor and we're not too close. And then
you could do that right while you're in the operating room.
Right,
know right away.
We know right away.
Called frozen section diagnosis. Yep. Now, I assume that you tried to remove the tumor plus a little bit of normal tissue?
Right. Generally, what we aim for is just a few millimeters of normal tissue right around the main tumor. And then the second part is we check the sentinel lymph node. So we take 1 or 2 or sometimes 3 lymph nodes out from under the arm. And they also go for frozen section pathology. And if they're negative, then we can, those patients may be suitable for catheter placement.
Now, the part that I read said that this also includes partial breast radiation. And I don't quite understand how it can be partial. Either you're getting breast radiation or you're not. So what makes it partial breast radiation?
So for this, we use a catheter. And
that means a small little plastic tube.
A little plastic tube. It looks a little bit when it's opened up like an umbrella that's facing another umbrella. So it has this basket-like configuration when it's expanded in the breast. And each of those little struts or each of those little arms that form part of the catheter can be used to dose the radiation. So it can be very focused and given exactly where it needs to be, but right at that lumpectomy cavity. So partial breast means just in that part of the breast where the breast tumor was and avoiding all the other quadrants of the breast.
So you put little radioactive pellets in there after you have the catheter in, or do you do it right? When do you do that?
So we don't have to do the little pellets anymore. Now
these are preloaded.
These aren't preloaded, but what happens is that 2 days following surgery, the treatments would begin. So the day following surgery, the patient meets with the radiation oncologist and they do a simulation. They take some integrated CT images that show how the catheter sits in the breast, and they do all their physics and plan how they're going to give the radiation. And when the radiation starts, they actually have a robot that comes into the room and attaches to each of these sources and serially sends a dose in for a predefined fraction of a second in each of those ports.
Oh, so it's external beam radiation directed by this catheter.
It's a radioactive source that's the same as those beads were, but now it's just given as a source that moves in and out rather than a beads having to be manually loaded in and out.
All right, and in just 10 days of radiation, or how many days of radiation?
So the whole thing, from the day of surgery till the day of completion of treatment, can be done within 10 days. So the radiation protocol that we have used is 5 days of radiation given twice daily on weekdays.
Oh my goodness! And
So-
what are the side effects of that radiation?
Yeah, what's not to like? What's not to like? It's pre-recorded, so she can get
I
that.
can edit
so,
that, yeah.
What's not to like?
So what's really nice is it's very convenient for people who work and want to have minimal disruption to their schedule. And it's super convenient for patients who live hundreds of miles from a radiation treatment facility and may forego radiation altogether.
The part that you mentioned, you said for now, postmenopausal women with, that fit these certain criteria. Does that mean that you're hoping to expand it out?
Right. So we've been talking within our groups about expanding this to women who may be perimenopausal or a bit younger. There are some national organizations that think partial breast radiation is reasonable for women who are as young as 40 or 45, and we've been fairly conservative in selecting candidates. Now we've treated a number of women, and I think we've seen very good results, and it's time to think about expanding our patient cohort a little bit.
It will be a few years, however, won't it, until you know for sure that this treatment is as effective as what you used to do, which would be external beam radiation from the outside for a longer period of time after the lumpectomy?
Right. There's several studies that have looked at partial breast radiation given either via catheter, given via external beam, or some even starting to look with protons that target a portion of the breast. So I think the safety data will be out relatively soon from these clinical trials. The concerns that have been raised about external beam is that you treat a larger volume of the breast. This is really focused to the area at highest risk.
And I would imagine the whole reason why you want to do this is so that you can preserve the breast, so that you don't have to do a removal.
Right. We don't have to remove the whole breast and do a mastectomy, and that we don't have to get the side effects of radiation treatment to the entire breast and then to other organs. So if you look at the really cool CT simulation images, you can see that the normal organs really don't get very much dose at all compared to external beam where they get some.
But this is really only for women with lower grade cancers that has not spread to the lymph nodes, that are perimenopausal or older than 50 right now, and they're estrogen receptor positive.
Correct.
What a great program.
So
Yeah, 10 days and you're done.
Just like that.
Yeah, I can't argue with that. Dr. Tina Hieken, breast surgeon, Mayo Clinic, Rochester, thanks so much for being with us.
Thank you.
We're going to take a short break, and when we come back, we'll learn more about the risks of taking blood thinning medications.